We have a couple questions from our audience, and Joe, I'm going to direct the first one to you because the program at Stanford has been less than a year. Can you speak to a question about how to actually bring peer support to the entire organization? It doesn't have to just be an error. Is there a way to make it more part of the culture of the things that you do? You shared with us the tragic shooting of one of your colleagues and how you were able to use peer support. Perhaps that would help answer this question.
Yes, unfortunately, our colleague Mike Davidson was shot in the hospital and killed, and had there was about 8 hours worth of unbelievably intensive work, care, intraoperatively to try to save his life. And we had the peer support available and knew that if there's an event so traumatic that is likely to affect our colleagues, that this is exactly the time we'd want to offer that. And so what we did was we offered a series of group peer support. For all the different groups we could think of who might have in any way been involved or affected. And that was, of course, a ripple effect, not just those of us who knew him, but people who worked with him a lot, or people who were in the clinic or what have you. There were so many healthcare team members who were affected. So we used both the group peer support, as I said, and then we also understood that there were individual clinicians who were really, really going to be impacted. Not necessarily, but we thought they were so at risk for, and at risk for feeling awful after this, and also deserving of the support. So we mobilized all of our trained peer supporters and assigned one-on-one outreach to each of the clinicians. One thing that we did do in that instance that has changed a little bit, my thought around the peer support outreach is, in this setting where the trauma was so high, the emotional fallout, is usually when I would reach out to a peer for support, I would say, would it explain the program? Would it be helpful to sit to talk? I would ask them that question, and if they said yes, we would talk, and if not, that's fine. But in this instance, I actually would reach out and say, do you have a couple minutes? I just want to meet with you. And I found that just sitting with people who I think likely might have said, no thanks, I'm fine, just because a lot of my colleagues are surgeons and anesthesiologists, sort of more like, I'm tough and it's okay, I can deal with this even though it's horrible. Just sitting with them and letting them just talk about what they went through, I think was helpful. At least that was the feedback that I got directly from them. So we learned from that sometimes really even just being more present and providing that I'm sitting here with you as a colleague can be really, really powerful.
Thank you. Thank you for sharing that story. Brian, you talked a little bit about it, the confidentiality issues, not so much from a risk standpoint, but just in California, we're lucky we have CEC 1157, which protects certain things from discoverability. How were you able to help sort of smooth the concerns about confidentiality through the organization to allow people to feel like they could use the peer support program?
It was a remarkably persistent issue because, as Dana says, in California we have protection because this is a medical staff initiated program. It's a quality improvement program. It falls under the protection of our state law that protects from discovery those sorts of activities. And so we would say that, but people were not really believing it. And so it basically just took conversations and repeated reassurance that this wasn't being written down, for one thing, that there was not a record kept of any of the content of what we were talking about, and then that even if someone was subpoenaed to talk about what the conversation, what was the content of the conversation, they would not have to respond to that subpoena. It would be protected. And so really it's a non-issue. It's just that it just, I think, highlights the sensitivity of folks when they're in these kinds of situations that they're vulnerable. They feel a sense of vulnerability, and it's hard to reassure them that they're safe.
Right. Well, and Jane, as you know, in Massachusetts, these are not protected conversations, and we really wrestled with our risk managers and our medical malpractice insurers, CRICO, and the defense malpractice attorneys, and we really talked a lot about, well, how can we do this if it makes clinicians vulnerable to having the conversation discovered? with the lawsuit. And we actually decided we're going to do this because it's the right thing to do. Of course it should be protected, but it isn't. And rather than changing the law, which I'm not in a position to do, we are going to do it. And we're going to put certain safeguards in, as Brian mentioned. We don't take any notes for any of the conversations. We actually just, this is off the record, if you will. And we don't. I mean, we listen to what happened with the event, but we're really not there in a judging kind of technical root cause analysis kind of mindset. So we're still doing it, and it seems it's interesting. It seems okay. People accept that it's part of the program and it's blessed by the institution. So I guess it's okay.